So we're going to talk about PSMA. We've had a lot of talks about imaging, but I'm going to focus this talk, because it's brief, really just on the use of PSMA imaging in the setting of biochemical recurrence rather than in newly diagnosed disease, which I think is quite fascinating as well. So these are my disclosures. So as we all know, there are many scenarios in which we need better imaging in prostate cancer. We've talked mostly at this meeting about initial diagnosis. We've, with MRI, with micro ultrasound this morning quite a bit, et cetera. But we also, of course, need better imaging literally along the entire continuum of prostate cancer progression to help us manage patients, make better management decisions. So I'm going to focus today really on the common scenario that we all confront of a rising PSA. And that can be, honestly, it can be after radical prostatectomy, after radiation, and I think we will see, we expect to be seeing this also after focal therapy, obviously. And the questions may be different depending on the different scenarios, so that would be interesting to see that play out. But the idea, of course, is to identify the location of disease with the hope that if you know where it is, you'll be able to treat it better than we currently do. So we all know, I think, at this point, this has now been around for a number of years, what PSMA is. It's a cell surface protein. It's an enzyme. It's overexpressed in most prostate cancers, but not all. So that's important to recognize, particularly in the setting of metastatic castration-resistant prostate cancer, like the case we talked about this morning. There are many ways to target this, or as a target for both therapy and for imaging. You can use antibodies. I've done a lot of work in this area of using engineered antibody fragments. J591 was developed by Neil Bander's group probably almost 20 years ago and has been explored in the setting of imaging. And then because it's an enzyme, many small molecules that bind to the enzymatic area of activity have been developed, and those are the ones that really have made the biggest impact in terms of what we're doing in the clinic right now. So this is a review, and I think this is a meta-analysis that now is already almost 4 years old from Australia, from Nathan Larenchik's group, looking at the performance of gallium PSMA PET. So this is probably the small molecule ligand that's had the most exposure worldwide, but there are others which we can talk about that are emerging. This one is labeled with gallium. It's a positron emitter. It has to be produced on site, which is a limitation of it for many centers in terms of just the practicalities of using this. But there have been many studies throughout Australia, throughout Europe, and increasingly I'll show you some data from the United States as well. But basically, they all say the same thing. The higher the PSA is, the more likely PSMA gallium is likely to detect prostate cancer somewhere. Not necessarily everywhere, but somewhere on a per patient basis. And the numbers that they came out to here are 48% with a PSA of 0.2, 56% with a PSA of 0.5, and 70% at a PSA of 1. So these are, of course, detection rates rather than necessarily absolute sensitivity for a diagnosis of all sites of disease. And that's important to recognize. There were a number of earlier papers comparing this to choline that demonstrated clearly that PSMA is superior to choline, which really was the best tracer that we had prior to PSMA. So at UCLA and UCSF, we started doing PSMA PET now more than 4 years ago. We've got quite a few different protocols that have been done under an IND. And we recently went to the FDA to start the process of getting approval for gallium PSMA in the United States. And this is the publication from Lancet Oncology, where we reported the prospective study of patients with biochemical recurrence among the two sites. And it's very similar to the results that were published in the meta-analysis. PSA is less than 0.5. We saw disease in 40% of patients. 0.5 to 1, 57%, getting all the way up to 97% of patients with PSA greater than 5. Importantly, PSA doubling time did not seem to make a difference in terms of the detection rate. So the detection rates were the same whether the PSA doubling time was short or long. It also didn't seem to make a difference what the PSA nadir after prostatectomy was, low or high. The detection rates were quite similar and certainly not statistically different. I think the most fascinating thing about working in this area the last 4 years is simply the distribution of lesions that we're seeing. I thought that we knew a lot about prostate cancer, lymph nodes, and bone, but I think what we've learned both from autopsy studies, but even in the setting of an early biochemical recurrence, is simply the distribution of lesions that even at a PSA less than 0.5, you see multiple regions in about 5-10%, you see bone in about 5-10%, you see a lot of pelvic nodes, you see extrapelvic non-bone disease as well, lymph nodes, particularly in the retroperitoneum, but we see subclavian nodes, all kinds of things, lung lesions quite commonly. And at least with PSMA gallium, the percentage of patients who actually have recurrence in the prostate bed is actually relatively low. So whether this is an artifact of of this tracer, which is excreted through the bladder and may obscure very small recurrences in the prostatic bed, we don't know. I'll show you some data with Axumin, which is not excreted through the kidneys, and there are PSMA ligands in development that also will not be excreted through the kidney, so they may turn out to be the best. But certainly, if we're doing salvage radiation to the prostate bed, you can see here we're going to be missing a whole lot, and that clearly explains why salvage radiation to the prostate bed is not effective in 50% or more patients. We also looked very carefully, because we also went to the FDA with this information, at validation that PSMA positive lesions were actually prostate cancer. And we did this both with a composite validation based on response to therapy as well as pathologic validation. But we also did histopathologic validation in quite a few patients as well. And regardless of how we did this validation, you can see that the positive predictive values were quite high, between 84 and 92%. If you look at the sensitivity for by confirmation at the time of surgery, these are generally lymph node dissections on a per patient or per region basis. Also, you get fairly high sensitivities for detection of recurrence based on pathologic confirmation. So certainly, this is a very good tracer. I can tell you it's not perfect. For many reasons. Number one, there are non-prostate cancer lesions that do express PSMA. And we had a case not too long ago of a guy who had a recurrence, PSA recurrence. We got a PSMA scan, and he had a small lesion in the anterior rectum. So we thought, well, I've never seen prostate cancer in the rectum, but maybe it's prostate cancer in the rectum. So we had gastroenterology go up there and biopsy it, and sure enough, it was a rectal cancer. And so certainly we have seen, and recently I had a guy who had a PSMA positive lesion in his stomach, and he had a GIST tumor. So you can pick up non-prostate cancers with PSMA PET. So you need to be careful, particularly if it's in a place that you haven't seen prostate cancer appear before. But it's kind of cool, the stuff that you see. So these are typical patients. You see many of these images, men who have PSAs 0.9, 0.6. They've got nodal recurrences. And the question, of course, is always what to do about these. And that's what I'm going to really spend the bulk of the talk talking about, what we don't know as opposed to really what we do know. This is kind of a cool case that we published as a case report. It's a man, 78 years old. He had a prostatectomy 16 years ago. I think this case is from 2 years ago now. He went in not because he had a PSA recurrence, but I think for lung cancer screening because he had been a smoker. And they found actually a lesion in his mediastinum. Somebody was smart and checked a PSA, gave me a call and I said, well, maybe in addition to FDG PET, you should get a PSMA PET. So sure enough, the PSMA PET showed this solitary lesion here in the mediastinum. And his FDG PET was negative in this case. He didn't have anything in bone. And so we took him, thoracic surgery, took him to the OR and resected this, and sure enough, it stained strongly for PSA. And his PSA actually went to 0 and it stayed 0 at least for 2 years. So interesting case, and not just a one-off. I've seen a number of cases like these. I'm taking care of one right now. So we also did, Jeremy Kelly, a nuclear medicine physician at UCLA, did together with us a prospective comparison of PSMA and Axumin. It's obviously an important question because Axumin right now is the only approved agent in the United States. So we enrolled 50 consecutive patients. who had biochemical recurrence with a threshold of PSA 0.2, which is generally the threshold I use for ordering a PSMA scan, given that patients are paying out of pocket for this exam, and I want to increase the likelihood that we're actually going to find something. So all patients had gallium PSMA and Axumin imaging within 2 weeks of each other. Readers were blinded to the other scan. We looked at inter-observer and intra-observer agreement, et cetera. And this was published recently in Lancet Oncology. And basically, the upshot is that gallium PSMA imaging was essentially twice as likely to detect a site of recurrence compared to Axumin. The only area where Axumin seemed to really outperform, as I mentioned earlier, is in the prostate bed, where lesions were seen in 18% with FACBC Axumin and only 14% with PSMA. So that certainly could be the one limitation of PSMA because of its excretion through the bladder. And putting in a catheter in everybody is difficult to do to obviate that problem. But if you look at every other site, bone, retroperitoneum, soft tissues, PSMA was clearly more sensitive for detection of site of recurrence compared to FACBC. And I think that kind of settles that question, and it's, I think, most people's observation. So the big question, of course, is, okay, we've got this great imaging, we've got these beautiful pictures, now what do we do with it? So the first question is, well, does it actually impact management? And there have now been at least 5, probably more studies now that I'm not aware of, that have prospectively asked the question, prior to imaging, what are you going to do? Post-imaging, what are you going to do? And have basically assessed the management changes. Our own study here by Jeremy, myself, and others, we showed a 53% change in management based on the results of PSMA imaging. That is essentially similar to all others. This one, 30% from Belgium. What we lack is data that this actually impacts long-term outcomes. And that's really kind of the holy grail. It's a complicated question that we need to get to. But certainly it's impacting our management. So if you ask the question, you should only order a test if you think it's going to actually impact what you do, I think the answer is clearly that PSMA does that. And I'll go through some examples of the ways that it may impact management. I think we know what they are. So let's say PSMA uptake is in the prostate bed only. Then the treatment option, instead of radiating the lymph nodes, might be to do radiation just to the prostate bed and avoid systemic treatment or radiation to the nodes. If they've got nodes in the pelvic regional lymph node chain, maybe just treat the nodes and avoid unnecessary prostate bed radiation. If they've got oligometastasis, which we now see so commonly because of PSMA imaging, you can consider SBRT or other therapy to the site of the disease, plus or minus ADT. And of course, if they've got metastatic disease, you may save a person unnecessary radiation or unnecessary surgery for that matter. This is, again, a typical case with a single lymph node, PSA 0.27. So the question is, well, I probably am not going to radiate the prostate bed, but should I? The radiation oncologists still want to do that. Should we do salvage radiation to the node? Should we treat all the nodes or just that single node? Should we use ADT? That's a separate question. Or should we even consider salvage lymphadenectomy? And if you look at our own data, and this is actually pretty similar to other data from Mayo Clinic and other places that have been published, the success rate of doing this is not all that great. So either using salvage surgery or salvage radiotherapy, targeting PET-positive lesions, only 30% achieve an undetectable PSA. That in most cases is maintained, but not always. Almost everybody has a PSA decline. Some people don't respond at all. So why do patients fail? It could be under detection of metastatic disease. Definitely yes, because PSMA will not detect lesions less than 2 or 3 millimeters, so you're going to miss them. And every time I do a salvage node dissection, there are more nodes that are positive than what we saw in the scan. Did we use the wrong template for radiation? Are the nodes that are involved actually outside the standard templates for radiation? Or is there inherent resistance to radiation? Although somebody said yesterday, there's no such thing as inherent resistance to radiation. I would beg to differ biologically, but we could discuss that later. So what are we doing to try and improve our ability to target PSMA lesions? In Europe, they're doing PSMA radio-guided surgery so that when you go in to do a salvage node dissection, you actually can find the node because it's not uncommon. It's a deep internal iliac node, and they're not always easy to find. We and others are also working on fluorescent imaging using PSMA ligands, and that's a really cool application. It's preclinical, and it's just entering the right now that I think will improve things. In terms of metastasis-directed therapy, this is the STOMP trial. It's one of a number of trials ongoing in the oligometastatic setting. Certainly by going after metastases that are detected by PSMA, you can get PSA declines, and at least the time to hormonal therapy is delayed. Whether that's really a valid endpoint is a big question mark. So this was a really great editorial from Chris Sweeney and his group at Dana-Farber that came out in JCO last year, and basically the title was, "Has PSMA PET Put the Cart in Front of the Horse?" In other words, we make management changes, but are these appropriate? Are we changing too much too soon without knowing exactly what we're doing? And I think the answer is, to some extent, yes. Certainly there are obvious situations where we know the management change is appropriate, but we don't always know that. So the final couple of slides is a clinical trial that we're doing at UCLA. It's already accruing very, very well. But basically to ask the question as to if we change our salvage radiation ports to lymph nodes based on PSMA imaging, will we get better outcomes clinically? So we all know, so these are distribution of PSMA lesions that we've seen in our studies, and many of them, some of them are outside the normal ports of distribution for radiation therapy. So the trial is very simple. Patients with a biochemical recurrence are randomized to either get salvage radiation immediately or to get PSMA followed by salvage radiation that's based on the results of the PSMA imaging. I think we've enrolled half of the patients so far, so it's going well, and we'll see whether this actually impacts management and outcomes overall. But I think really the big question for the future is not can we detect more, but can we actually manage better? Thanks very much.